Hey guys, in this video I would be explaining you about the various types of heart block. It is very confusing for us to read those difficult ECGs and all those complexities, that too in a very short amount of time during the exam. So I would like to make it really easy for you guys to distinguish between the various types of heart blocks. So for example, if you are given any type of ECG in the exam, you have to see the PR interval, PP interval, the type of KORS, the RR intervals. So your mindset should be in such a way that you catch that point, the main point, at the first glimpse of the ECG itself without wasting any further time. So the first type of heart block is first degree AV block. If AV block is there, it is so obvious that the conduction from the atria to the ventricle would be slowed. In the first degree AV block, the conduction from the atria to the ventricle is slowed. As a result, the PR interval would be prolonged, that is, it is more than 0.20 seconds. And what we see in this ECG here is that there are prolonged PR intervals, as you can see, more than normal, that is more than 5 small boxes. And why? Due to the slowing of the conduction from the atria to the ventricles. So PR interval would be more than 0.20 seconds. The PR interval remains constant. It is an important point that the PR interval will remain constant, and there is QRS complex for every P wave. That means there is no missing of any P wave or any QRS complex. So on the next page, I am showing you an enlarged view of this ECG. That is, the PR interval is more than 0.20 seconds, that is greater than 5 small boxes, as you can see here, at the beginning of the P wave and at the beginning of the Q wave. This is the PR interval and it is more than 5 small boxes. So what UWORD mentions is that most of the first degree AV block with normal QRS, we need to know, we have to differentiate in case of QRS complexes in first degree AV block also. If the QRS complex is normal, so there is no further evaluation needed. We need not do anything. It is just benign. So we have to just wait and watch and observe. Benign but first degree block is associated with a higher rate of heart failure, atrial fibrillation, and overall mortality. If the first degree heart block is with wide QRS, so if the QRS is wide, that is, the conduction delay is below the AV node. Here it was at the level of the AV node, here it is below the AV node, mostly bundle branches, and can have unpredictable progression to second or the third degree block. In this case, what would you do? Electrophysiological testing is very necessary to determine the side of the conduction delay in this case where there is wide QRS. UWORD also mentions that some patients with first degree AV block with marked prolongation of PR interval, for example, if the PR interval is markedly prolonged, these people can develop pacemaker syndrome. What is pacemaker syndrome? Uncomfortable sensation of awareness of the heartbeat. So the patient would be aware of his or her heartbeat, and that would be a very uncomfortable situation. Why it happens? Due to atrial contraction against a closed mitral valve during the ventricular systole. So as the ventricles are contracting, so the atrial contraction against a closed mitral valve during the ventricular systole, this would create a uncomfortable sensation of awareness of the heartbeat. Such symptomatic patients, for example, these patients, these are the potential candidates for the pacemaker explantation. This is important. So now I've prepared a summary of all the heart blocks at one page, which would make it very easier for you to understand. So as you can see, in the first degree heart block, the PR interval is increased. You can see that? Yeah, the PR interval is increased, more than 5 small boxes, and every P wave follows the QRS complex. Yeah, that you can also see. The the PR interval is constant but prolonged, and every P wave follows the QRS complex. Now, in the second degree AV block, so I would like to explain you the fact that the second degree AV block is divided into two types, that is Mobitz type 1 as well as Mobitz type 2. In case of Mobitz type 1, there is, you have to remember this word, this phrase, that there is progressive prolongation of the PR interval. Whenever you will get an ECG, you will see that, see, here the PR interval is quite less and it is increasing, right, with every beat. And after a few like prolongation of the PR intervals, there is a missing of the QRS complex here, you can see. So this is known as drop beat, that is absent QRS after the P wave, and this would be known as non-conducting P wave. It didn't conduct, right? So these are the most important words for second degree AV block Mobitz type 1. Whereas in Mobitz type 2, that the block is after that, the block is below the AV node. In case of Mobitz type 1, the block is at the level of the AV node. So if the block is below the level of the AV node, what would happen? See, as you can see, the PR intervals are like quite constant, right? So they are not increasing, there is no prolongation of the PR intervals, and the QRS complexes drop suddenly out of anywhere. They drop suddenly, not like in the type 1 where there was progressive prolongation of PR interval, and after a few PR intervals increased, there is a drop of QRS. Here it is dropping suddenly and the PR interval remains constant. In this case, you would definitely require a pacemaker, which is important, right? Then we come on to the third degree AV block with junctional escape. I would like to explain this thing. So as I have marked it, so see, you can see the PP interval is quite constant, right? As you can see my markings, and there would be P waves hidden in the QRS complexes as well. And the what is escape rhythm? Escape rhythm is independent conduction from the ventricles. That is, the ventricles would contract by themselves without needing any impulse generation from the atria. As you can see, the escape rhythms are so evident in this, and this definitely requires a pacemaker. And in these cases, drugs like digoxin, beta blocker, calcium channel blocker, all of these are contraindicated, and you have to first look for the reversible causes, right, before planting a pacemaker. And if the reversible causes are there, you won't go for the permanent pacemaker. Although transient pacemaker is, yes, it is required, but you don't need a permanent pacemaker in case of third degree AV block. And I also copied a table from UWord 2019. Let me see if I have it. Yeah, this is here. So this is a very important table from UWord which you need to memorize. For the second degree AV block, that is, they have differentiated Mobitz type 1 from Mobitz type 2. So in case of Mobitz type 1, the level of the block is at the AV node, whereas in case of Mobitz type 2, it is below the level of the AV node, that is bundle of His. This you got it? ECG findings, I have already explained to you that there is progressive prolongation of the PR interval leading to the non-conducting P wave, that is group beading or dropped miss. Whereas in case of Mobitz type 2, the PR interval remains constant with intermittent non-conducting P waves that we already discussed. The QRS complex in case of Mobitz type 1 is usually narrow, whereas in case of the Mobitz type 2 is narrow or wide. These are the few important points which we need to emphasize on. Exercise or atropine is improving type 1 Mobitz type 1, whereas it is worsening type 2 Mobitz type 2. Whereas the vagal maneuver, for example, carotid sinus massage, is worsening type 1 and paradoxically improving type 2 AV block. The risk of complete heart block is low in case of Mobitz type 1, whereas it is high in case of Mobitz type 2, and it is an indication for the pacemaker. So this was all about the AV blocks. I hope it made it quite easier for you to understand. Thank you so much for watching this video. For more such high yield content, please subscribe to my YouTube channel. God bless you all.